The number of Americans living with Alzheimer's disease has reached a new high. Today, the Alzheimer's Association is releasing new data from a national survey.
Every 65 seconds, someone in the United States gets diagnosed with Alzheimer's disease. Currently, there are 7.2 million Americans living with Alzheimer's disease. This makes up about 11% of our seniors. By 2050, this number is expected to double. Alzheimer's disease is not just an epidemic or a statistic. It is something that affects our loved ones. Imagine forgetting the laughter of your children. Imagine forgetting the moments that defined you, your core memories. That's what Alzheimer's does to people. It steals away the most important and core memories from people. But then the question arises, what exactly is Alzheimer's disease? There are two ways to answer this question. Number one, what can we see clinically or in our day-to-day life? And number two, what happens in our brain? And this is exactly what we are going to do in this video. Number one, we are going to learn how is the Alzheimer's disease defined. And number two, we are going to have some fun pathology review for Alzheimer's disease. Now, the story of Alzheimer's disease is not just a boring scientific story, but this is the history of human tenacity and curiosity and how the scientific discoveries constantly affect how clinically Alzheimer's disease is diagnosed. Now, back in the old day, if you went to the doctor's office and you were having memory problems and you were above the age of 65, you could get a diagnosis of Alzheimer's disease very easily because that was the definition of Alzheimer's disease. But these days, you hear everyone talking about the PET amyloid, the CSF studies, the blood biomarkers. And the reason for that is that we are having frequent revisions of the Alzheimer's definition, and this is affected by the research that we are having, and eventually these definitions affect the clinical practice. Now, the story of Alzheimer's disease starts with Alois Alzheimer. He was a physician back in the day who came across a patient who was having memory problems, and after she passed away, he looked at her brain under the microscope and he saw amyloid plaques and tau tangles. Now, this is exactly what we were talking about earlier, having a clinical picture, that is what we can see when individuals are alive in their day-to-day life, that okay, someone is having memory problems, but also looking at the pathology. Oh, when we look at their brain under the microscope, they have amyloid and tau. This was how Alzheimer's disease was very first described. Now, fast forward to 1984, when we had the first formal definition of Alzheimer's disease. Now, in 1984, the definition said to have Alzheimer's disease, you should have dementia. And I see this so common when people say, do I have Alzheimer's disease? Do I have dementia? Well, these two are slightly different, and we'll talk about how they are different. Now, dementia means that someone is having cognitive difficulties to the level that it affects their day-to-day activities. More specifically, the instrumental activities of daily living, such as medications, driving, your finances, appointments, things like that. When these start getting affected due to cognitive impairment, we say someone has dementia. But here, as I said earlier, you're just looking at the clinical symptoms, but you do not know why they have dementia. That's where we look at pathology. So in 1984, how Alzheimer's disease was diagnosed was, we said the individual should have dementia. That is, their level of cognitive impairment should be to the degree that it affects their day-to-day functioning. And in addition to having dementia, they should also have one of the cognitive domain that is affected, and that should be memory difficulties. So they should have short-term memory impairments. That is, we have talked about something, and after a while, we don't remember, and we repeat questions and conversations. Now, in addition to having memory problems, individuals should also have 2 or more cognitive domains affected. This could be executive function problems such as decision making, planning, and judgment. And then the other cognitive domain that could be affected was language. So this includes tip of the tongue problem or the word finding issues with reading, writing, and such. And last but not the least, the visuospatial issues. Now these are navigational issues, recognizing people's faces, knowing what objects are, their names, and what they do. Now if someone had dementia, memory issues, 2 or more cognitive domains affected, they could be said to meet the criteria for probable Alzheimer's disease. This was the highest level of certainty you can get when someone was alive in terms of their Alzheimer's disease diagnosis. Now remember how we talked about, we kind of think about Alzheimer's disease in terms of what we see clinically and what we can see under the microscope. So the highest level of certainty someone can get in terms of their Alzheimer's disease was probable Alzheimer's disease if they met these 1984 criteria at that time. But say if someone passed away and we looked at their brain under the microscope and we saw amyloid plaques and tau tangles, then they would meet the criteria for definite Alzheimer's disease. So as you can see, this was purely clinical criteria, talking mostly about individuals' symptoms when they were alive. Then came the 2011 criteria, a major shift in thinking. Now at this time, what we realized was that individuals can have a spectrum of cognitive complaints or cognitive status despite having Alzheimer's pathology. So individuals can have amyloid and tau in their brains, but clinically looking at them, they can be normal, they can have mild cognitive impairment, or they can have dementia. Now, wait a minute, was mild cognitive impairment? Well, mild cognitive impairment is a step before dementia, wherein you are noticing some cognitive problems. Your neurologist, when they do a screening test or an extensive neuropsychological test, they also notice objective cognitive issues. That is when we say this individual has mild cognitive impairment. So the first big thing 2011 criteria did was to acknowledge that you don't need to have dementia. You can also have mild cognitive impairment and have that due to Alzheimer's pathology. Number 2, it did mention that there are biomarkers that are available which one could use in the research setting, but since there were no anti-amyloid medications at that time, they did not recommend doing it for clinical purposes. By that, what they implied to say was that we were noticing new biomarkers, both amyloid and tau biomarkers that were available, and their reasoning was just the clinical picture of probable Alzheimer's disease was about 81% sensitive and 70% specific for Alzheimer's pathology. Now, in 2011, in life, to have the diagnosis of probable Alzheimer's disease, you need to have insidious onset of your cognitive issues. They should be worsening or progressive, and then you could have either memory issues or executive function issues or language issues or visuospatial issues. In addition, you should not have symptoms of other dementias such as Lewy body dementia or frontotemporal dementia. The biomarkers mentioned in the 2011 paper included 2 big categories. Number 1 was the amyloid, that included the CSF amyloid beta 42 as well as the PET amyloid, and number 2 was the other category that was tau and neurodegeneration, and tau included phosphorylated or p-tau, total or t-tau, And the FDG PET, this is a PET study to look at the metabolism of your brain, as well as MRI picture of your brain to look at the atrophy pattern. So to summarize, you could say the 2011 criteria took into account the biomarkers that were being developed, but it's still focused on a very clinical picture. What am I seeing clinically when the patient comes to me? Fast forward to 2018, we're now having some drugs in development, and we want to make sure that individuals who are getting the anti-amyloid therapies actually have amyloid in the brain, because it would be really strange to give individuals an anti-amyloid drug when they don't have amyloid in the brain. So 2018 criteria or definition of Alzheimer's was very focused on this research definition of Alzheimer's disease. So this was mostly for research studies, the investigational studies that were looking at the drugs that were being developed. So it made sense that in 2018 a pathologic definition of Alzheimer's was given, so kind of focusing on just the pathology of having amyloid and tau in the brain was sufficient to get you a diagnosis of Alzheimer's disease, no matter what clinical symptoms you have, which was a major shift in the thinking. But again, this was not intended to be used in clinics. This was entirely for research purposes. So this major shift in thinking about a clinical syndrome as a combination of symptoms that people have that may reflect that someone has a pathology in the brain, versus thinking about this pathology purely, was the first big change in 2018. It was really groundbreaking. And the way they broke down the biomarkers was that in addition to the amyloid and the tau that was already broken down in 2011, we also had a breakdown of tau and neurodegeneration further into tau and neurodegeneration as one separate category. So we had 3 categories of biomarker. The first one was amyloid, which could be looked at in the brain with a PET amyloid or a CSF amyloid. The number 2 biomarker that was talked about in 2018 criteria was the tau. So that was phosphorylated tau in the CSF or the PET tau imaging study that we could do. Interestingly, in this paper as compared to 2011, the tau, whether p-tau or t-tau, were put into separate categories. So p-tau or the phosphorylated tau was put in the category under the tau biomarker, but t-tau or the total tau was put under the neurodegeneration biomarker category. And why is that? And what is this third category that we are talking about? The typical progression is thought to be that amyloid comes first, then we have tau, and then shortly after having tau, you have neurodegeneration or breakdown of cells in the brain that lead to brain shrinkage or atrophy. But as you know, there can be any pathology that can do this neurodegeneration, and we can see an elevated t-tau in other pathologies as well. We can see the shrinkage of the brain in other pathologies. We can also see a low metabolism of the brain in other pathologies. So we have a neurodegeneration category that can happen in Alzheimer's disease, but we know that this is a little bit non-specific, as it can happen in other kinds of dementias. So per the 2018 criteria, if you have amyloid and if you have tau, you have Alzheimer's disease. Neurodegeneration you may have or you may not have. It's not necessary for the diagnosis of Alzheimer's disease. Now, this is a good criteria to have because this was developed for research, but in 2023 we had lecanemab approved, and then in 2024 we had donanemab approved. So even though these were research criteria, now we have these medications that we can give to individuals who are having cognitive difficulties, and we also have these studies that we can do in individuals who are alive, like PET amyloid or CSF, and look at the pathology in the brain as well. So even though it was a biological definition meant for research, it did kind of made its way into the clinical use. Fast forward to 2024, a really exciting time. We have two different kinds of definitions that emerge. One is by Alzheimer's Association, other one is by the International Working Group. And the way they're different is they're talking about these individuals who are normal but have amyloid in the brain and may also have tau in the brain. But let's talk about them one by one. So in 2024, after we have had these drugs in the market which could be used, Alzheimer's Association came up with a definition, and the way it was different from 2018 criteria was it broke down the biomarkers into core 1 and core 2. So no more amyloid, tau, and neurodegeneration, but rather core 1 and core 2. Now core 1, you can have positivity of amyloid through PET amyloid study, CSF amyloid study, or an accurate plasma test. That is a blood test, which was exciting. And this was enough for you to get a diagnosis of Alzheimer's disease, which is a big change from the previous diagnosis where we needed to have amyloid as well as tau to get the Alzheimer's disease diagnosis. Now, the tau biomarkers in this criteria were also broken down into T1 and T2, and T1 did fall under the core 1 biomarkers. Now, this is p-tau217 in the blood. This, although it has the name of tau in the blood, it actually correlates with amyloid in the brain, which is really confusing to think about, but basically think about it as a marker of positive amyloid in the brain, even though it says tau. So that's the core 1 biomarkers. The core 2 biomarkers, on the other hand, these are the tau that we talked about earlier, as well as the neurodegeneration. The core 2 is giving you information about the staging of the disease, meaning if you have amyloid, you're in the early stages of the disease. If you have tau, you're further along in the disease, and if you have neurodegeneration, further along. Now, the big point of controversy with this was the fact that they said for individuals who are cognitively normal but have this pathology of amyloid alone can be diagnosed with Alzheimer's disease. But then the International Working Group put together a criteria, and they talked about this clinical and pathologic diagnosis of Alzheimer's disease. So they said to diagnose someone with Alzheimer's disease, you need to have cognitive impairment that is objective, as well as you need to have amyloid and tau. So no more individuals who have some subjective changes of cognitive impairment, but when they test, their cognition is normal. Also, no more individuals who have normal cognition. They should not be diagnosed with Alzheimer's disease. So this is a time where we have these two different viewpoints, and both rightfully so and interesting. But what is my verdict on all of this? I am a behavioral neurologist. I see patients with possibly Alzheimer's disease every single day. And how do I kind of think around all these differing and quick changes in the definitions and new development of biomarkers, new drugs? Well, my verdict is that these are expert consensus. So meaning a group of people who are considered experts gave their recommendation for defining the disease. They are the best estimates of the ground truth, but they're not the ground truth. And we are all trying our best to find what is the ground truth and how to define the disease best so that we can treat and manage our patients the best. And all of this comes with the knowledge that as we are going to know more about Alzheimer's disease, as our understanding improves, our definition is going to improve more. Now, the next section of this talk, I am really excited about it. So these are brain cells that we are going to look at to kind of talk through what really happens in Alzheimer's disease. So I'll take my friend's neuron number 1 and I'll talk about what happens in Alzheimer's pathology. So the number 1 change we have talked about in this video is the amyloid protein. But where does this protein come from? Well, we have a small little protein on the top, the red protein that you see on the top of our pretty neuron head. Now this is a protein that we call as amyloid precursor protein. It is halfway in our brain cell, this part, and halfway it kind of sticks out of the brain cell. So it's also called as transmembrane, spanning the membrane of the cell, and it has important functions in transportation of things from outside the cell to inside the cells. And usually the breakdown of this protein product should not be sticky. And the way that happens is that, this part of the protein is the stickiest part, so it should be broken down into smaller pieces when the enzymes degrade this protein. But when that does not happen, and this part of the protein, the needle part of the protein, when it is intact, it kind of starts accumulating outside the cells. And what happens is that these little sticky proteins are kind of getting accumulated outside the brain, and eventually they kind of form this big sticky ball, and it sits at the foot end of the neuron. Sometimes it sits at the head end of the neuron. But what it does is essentially it does not let one neuron communicate with the other neuron because it's kind of sitting in between. And so not only physically it sits outside the cells and doesn't let them communicate, but it also eventually leads to inflammation, and it kind of leads to the death of this portion here, which we call as synapses, or the communication channels between the neurons. Now, what does it do in terms of tau? Well, here we have some pom-pom balls stuck to this neuron as well as this neuron, but what is sticking it very well is this cellophane tape in both the cases. This is exactly what tau protein does in our brain cells. It is a glue for the skeleton of our cell to be intact, and when the skeleton of the cell is intact, all the proteins or all the nutrients can flow easily. But if there's amyloid that is sitting outside the cells, it kind of causes release of an enzyme which will phosphorylate the tau. That is how we make p-tau, and it kind of detaches the t-tau. And as the t-tau gets phosphorylated, it kind of falls off from the cytoskeleton, and unfortunately, this also leads to the breakdown of this pathway or this structure in our brain, and eventually, because that happens, we don't have any good skeleton to hold this big part of our brain cell, this also dies away. And if there are no transportation to the body of the cell, this eventually will also die away. And that is how, once the amyloid comes, then the tau is phosphorylated, so p-tau, and then neurodegeneration, that is the death of our poor cells, happens. And when the death of the cells happen, we also have total or t-tau release in our CSF or the spinal fluid. So hopefully this video was a helpful review. In the next video, we're going to learn about Lewy body disease. Till then, take care and goodbye.